Okay, I hope everyone can see that.
Yep, we can.
Beautiful. So as was said, my name's Kaitlyn. I'm one of the Year 4Cs from the postgrad cohort. So today I'll just be going through the endocrine matrix that you guys have. And if you have any questions, feel free to privately message me or send me an email at the end. Okay. So roughly how today will run is this is obviously your matrix. I assume that things haven't changed from when it was sent through to me last. It is quite similar to ours from last year. So I'll do my best to run through that. There is a couple of topics that I've left out today, which include the obesity and hyperlipidemia, dyslipidemia. I do know that you had some conversations regarding some of these topics yesterday in cardiovascular. And obesity tends to be things that are quite easily picked up in an exam setting, so I didn't cover that for the purposes of today. Again, this is the last couple of days. Amazingly, last year was quite a different year for endocrinology in that the amount of marks allocated to endocrinology was a lot higher than previous years. And I think people had underestimated that a little bit. So that was unexpected and a good reason to revise on this topic as well. Okay, so just before we start, I'll just run through some revision of the anatomy of the endocrine system. So obviously we have the hypothalamus that stimulates the anterior posterior pituitary to secrete the relevant hormones. Obviously, in terms of the posterior pituitary, the layout is slightly different in terms of where the hormones are released from and how they act on their sites. But this is something that you can have a look at yourselves as well. I do find that this is a good summary, particularly at looking at the functions of each of the organs, particularly considering the impacts of hypersecretion of any of these hormones and the impacts that that'll have for the person. It will also help you to both this year and next year when you'll look at some of the other hormones that we don't look at so much in 3B. Finally, I think this is, if you remember one slide, this is probably the one to remember, remembering what hormones are triggered from the hypothalamus, having their effects in the anterior pituitary, and then their ultimate impact on the organs and the relevant hormones involved in that process as well. If you can have a good understanding of this, you'll do quite well for the rest of the lecture, and particularly with the practice questions as well. Okay, so I'd just like to start with a question. So if you guys would like to either send me a message privately with the answer and just see how you go. Okay, great. Well done, everyone. So as has been sent through to me, this case, hopefully everyone's had a chance to have a read through, is diabetic ketoacidosis. So the reason that this is the case and the reason that some people may get caught out is they may just include type 1 diabetes mellitus as well. They haven't in this question. They've been quite nice, but the thing is to remember that this is the best explanation for these symptoms is DKA. All right, and I've just got two questions here, more looking from a medication perspective. Okay, great. Everyone looks to be doing really well with these topics, which is great. Diabetes is I don't like the word high yield, but it is quite important, particularly this year and next year as well, that we have a good understanding of which medications we use in this setting. So the first one, it's a first presentation in an older adult. So obviously this tells us straight away that we can probably rule out type 1 diabetes. And also given a high BMI as well, this would be more indicative of type 2. And once you have that information, it's really about knowing what's first line in management of type 2 diabetes, which is metformin, so that's F. In the case of question 50, we're looking at an 18-year-old man, which obviously you would think is less likely to have developed type 2 diabetes by this point in time. And so it's likely he's type 1. Obviously, it helps as well that they've told you that he's given himself his insulin. And again, that would not be first line in a type 2 patient, which would suggest that it's definitely type 1. From these signs of collapse, we'll go through the signs of hypoglycemia shortly. However, this would suggest that he needs some glucose, and the best option in this scenario is glucagon. All right, last question before we move on to the next question. This one again is quite similar, actually. Just waiting to see if I get a few more answers. We are getting a bit of a mix in this case. Okay, so we'll have a look at this question. So 52-year-old lady, newly diagnosed type 2. So we've got the diagnosis confirmed. We can see from her weight that she would be considered obese to some degree, depending on her height. Her HbA1c of 9.1 is extremely high, and because that has been confirmed as diabetes, obviously this is something that we can use to guide our therapy. Now, serum creatinine, you're often given to what's normal. This would appear to be a normal serum creatinine. So for that reason, we can consider that medications that require adjustment in renal impairment are not a problem in this situation. So for that reason, I would say that the answer in this question is metformin. Again, because it is our first line agent in type 2, and despite the fact that it's unlikely to get her HbA1c down as much as we would like it to be, it's still our first line option. In terms of other options that I was given in the little chat, included perindopril, which is a valid point in terms of our secondary prevention of cardiovascular disease in a patient with diabetes. However, we don't have any information at this point to suggest that she is hypertensive. And so that we can't really say that that's the most appropriate at this stage. The other answer that I received was pioglitazone, which we'll talk about in a little bit more detail further down the track. But this is generally an agent that isn't used very often anymore. Pioglitazone and rosiglitazone have gone out of favour because they have been associated in some patients with worsening heart failure. So they're quite unfavoured in terms of management of diabetes. All right, so based on this, I was going to start with type 1. Oh, sorry, someone's just asked me a question. So metformin is considered a nephrotoxin. So when you have decreased renal function, we decrease the dose of metformin, and once the EGFR is less than 30, it's generally not something that we continue to use. And if we do so, we have to keep a good eye on the renal function. In terms of the drug groups that they belong to, you'll see in the next few slides which groups they belong to. So for type 1 diabetes, it's obviously a type 4 hypersensitivity reaction. of the beta islet cells to the beta islet cells, in our pancreas. And generally people have a good understanding that once we have an autoimmune response, we lose the function of that organ. And in this case, that means that we lose the effects of insulin. For this reason, the glucose can't be taken up into cells, and therefore we can't use that energy. So for that reason, we've got an accumulation of glucose in the blood without it being in the cells. And so the liver continues to pump out more sugar. And we continue to do this in an attempt to use up that energy. But instead it gets to a point where we start using fatty acids for energy, which form ketone bodies. And they are obviously acidic in nature, leading to DKA and metabolic acidosis associated with that. So you'll notice that I've highlighted important facts for you to remember. I haven't gone into every explicit detail today because I think at this point in the year, you just need the essential facts. There are points that may come up that may not be in these slides, but I've really tried to include the really important information in a way that you guys can digest it this close to exams. So generally it's in the younger population that we see this, and they can have a history of autoimmune disease. There can be genetics involved, but this is generally predominantly in the case of type 2 rather than type 1. And in terms of symptoms, we can have the polyphagia, polydipsia, polyuria, and in some cases nocturia, but that's not always easy to detect, particularly in younger children. Obviously, they can present acutely in DKA, and leading up to this presentation of DKA, they can lose weight and be quite fatigued in the lead up to that. I've kept this information in this little box. This is really the most important part of the slides, is knowing the diagnostic criteria. And in this case, this actually repeats for type 1 and type 2. So if you can try and remember these numbers, that would be great. So again, I've repeated them up the top here. And the important thing about with any diabetes is that you always need 2 positive tests on 2 different days to confirm the diagnosis. So if someone came into a clinic and you did a random blood glucose and it was elevated, whilst you may think that they have diabetes, you actually need another positive test to confirm that. The only exclusion to this is the oral glucose tolerance test, where you obviously, I don't know if you guys understand how that works, but we start off with an initial blood test at what we call 0 hours. It's most commonly used in pregnant ladies. Little bit, a dose of oral glucose, and then we repeat a blood test at 1 and 2 hours. Now, obviously, depending on the results of that, that can tell us if there's multiple elevated readings that they're diabetic based on that one result, but this isn't always the case, so it does depend on the individual patient. In terms of investigations, you'll find that these are quite common to type 1 and type 2. So obviously BSL is crucially important. Urine dipstick can detect signs of advanced diabetes and the complications of that. And in terms of bloods, looking at other cardiovascular risk factors are important. Just a reminder, the HbA1c is a great indicator of the past 3 months of blood glucose control, which is good in terms of assessing patients' compliance to therapy. But there are reasons why we don't always use that in our diagnostic framework. In particular, in type 1 diabetes, we do also have the antibodies that can be detected, the anti-GAD and anti-islet cell antibodies. C-peptide levels also allow us to differentiate between type 1 and type 2 in a patient where the diagnosis may be questionable. And finally, the autoimmune screen. As I mentioned before, autoimmune conditions tend to come together, so you can screen for these other diseases at the time of diagnosis as well. In terms of managing type 1, we obviously want to keep our blood sugar level within target. And so you can see down here I've highlighted preprandially we would like it to be between 4 and 8, and postprandially between 5 and 10. And so in the case of type 1 diabetes, the only way that we can manage this condition is with the use of insulin. Now, in terms of dosing of insulin, we can have mixed insulins, which have a long-acting or medium-acting insulin plus a fast-acting insulin in the one needle. And in that case, patients can give that to themselves twice a day. and then that would just be split dosing. The other option, which does provide better control, is basal bolus. So that's when the patient gives themselves one long-acting injection daily as a general rule. Sometimes you can see it twice a day, but most commonly it'll be once a day. And then they will give themselves boluses of short-acting insulin, where they give themselves small doses, adjusting that dose for the amount of carbohydrates that they're taking in and giving that to themselves prior to meals. These insulins act quickly and help to reduce the glucose at an appropriate time. The other option, which is becoming more popular, is the use of a pump. And this is when the patient calculates their carbohydrates that they're taking in, inputs it into their pump, and the pump manages their insulin requirements over the day. These pumps only use short-acting insulin, so it can be quite hit and miss if they incorrectly calculate their carbohydrates, and obviously requires a lot of education. Unfortunately, despite this, though, the pump does get the best results in terms of glycemic control. So if we can educate patients to do that, we will. Finally, in the management of type 1, it's important to consider other aspects of the management as well. So involving multidisciplinary teams is always great to mention in OSCEs. Don't forget that you don't have to know it all yourself, and that these people are really important. With all diabetes, considering other cardiovascular risk is important, and because of the complications involving optometrists and dietitians and that sort of thing is really important. Obviously in type 1 there is the risk of hypoglycemic attacks due to overdosing of insulin, and that's something that you need to educate patients on as well. In the acute sense, type 1 can present with DKA, which I did explain to you before. I've highlighted here on the left some symptoms that can differ. And in terms of that, that includes nausea, vomiting, abdo pain, Kussmaul's breathing, and the ketotic breath. And the biggest thing with any DKA is the dehydration. So I've included here the management of DKA. It's become a little bit unclear to me now as to whether that's content for 3Bs or 4Cs, but either way, have a look at that. So ABC should always be your approach thing. And obviously that was highlighted in our OSCEs last year as well. And there's a little acronym that we've got here, which is SPIDER. So the supportive management, potassium replacement, insulin, dextrose, eating nothings and ill by mouth, and then identifying the reason and treating that to prevent further illness. I've included over here in this box here the common precipitants for DKA as well. In terms of hypoglycemia, why is APO fluid overload a complication? Okay, so I'll just answer that while we're here. So when you are treating DKA, you are required to give fluids, because fluids help to actually manage the high levels of glucose in the blood and the acidosis as well. And the problem is that we do this quite slowly, and the risk is that we can have fluid shifts, and that's why we can get cerebral edema, where the fluid shifts into the cells of the brain, and this is when we can need things like mannitol. And just generally, if we give them too much fluid without thinking too much through it, we can cause fluid overload and APO in any patient, regardless of how fit and healthy they are. And the other thing is these patients are quite sick, so you do have to be quite cautious of fluid management. In terms of hypoglycemia, it's normally when a BSL is under 4. And we can see symptoms split into adrenergic and neuroglycopenic symptoms, which basically just mean the adrenergic symptoms and the brain's response to having low sugar. So in terms of autonomic symptoms, we can see the pale skin, sweating, shaking, and feeling anxious and palpitations. In terms of the effects on the brain, you would expect that you'd be less able to concentrate, you'd feel hungry, you'd become confused and start acting unusually. And eventually with progression of that, there's also consciousness and seizures. Obviously, to manage this, patients can be quite aware, but they can also not be aware of their symptoms in some cases. Depends on how tightly their glucose has been controlled prior to now. So making sure that the patient's safe and knows how to manage their own hypos is important. And depending on where they are, if they're in the community, making sure they've got jelly beans or a can of soft drink or something in their bag that they can use. They can also carry glucagon intramuscular injections, which comes in a little kit that can be given if it's severe symptoms. And the other thing is that after they give themselves that, they still need a longer acting carbohydrate, such as a sandwich, to prolong that control of their sugar. They will need to keep testing their blood glucose in that time, as we normally don't give the long acting carb until their blood sugar level is back within target. And for any patient that develops hypos, this can have implications on driving and safety. So it's important to educate, but also encourage GP follow-up if they're having recurrent attacks of hypoglycemia. The next one is type 2 diabetes, and obviously the difference here is that it's an accumulated response to high levels of glucose, and so we start to see insulin resistance, where the cells are less responsive to insulin, and therefore the pancreas pumps out more insulin and eventually becomes tired of doing this and becomes deficient eventually with advanced disease. Okay, I just got another question, Chelsea. I'll just come back to your question shortly. So diabetes type 2 is obviously far more common than type 1, and it's important to assess risk factors in your discussions with them as well when you're doing OSCEs. These are really useful, particularly this year when it's going to be a lot more history taking in OSCEs, and so assessing these risk factors really show that you know your knowledge, essentially. In terms of symptoms, it is quite similar, but we don't get that presentation of DKA because we still do have some action of insulin in the body, so we don't see that acute episodic symptoms. In terms of one additional thing that's always useful to look for is acanthosis nigricans, which is the pigmenting of the skin folds, as you can see in this picture. I've just been asked why we are replacing potassium and giving insulin to lower potassium. So generally when insulin goes into the cell, potassium will follow with it. And so when you're giving doses of insulin in the case of DKA, you are causing a shift of potassium into the cell, which can cause hypokalemia in the blood. And obviously this has impacts in terms of your cardiac health and in terms of causing arrhythmias. So we do need to replace potassium to make up for that shift that we're getting into the cell when we're giving insulin as well. I hope that answers the question. I won't go through these again, but it is quite similar with type 2 to type 1. And it's again follow-up in terms of acutely and then also in the longer term is useful to have an approach to both. In terms of management of diabetes, this is definitely to look at and looking at options as to when to increase or add on another agent. So as I've mentioned with the questions previously, metformin is our first line agent, but if the patient's HbA1c or blood sugars aren't excessively high, we can try diet control of their diabetes in the initial 3-month period, and then we would review that and assess whether that's been enough to get their blood sugars down. If not, we can obviously then add in what is normally first line is metformin. I'll go through some of the side effects of these as well, but sulfonylureas and insulin are less preferred only because they have higher chances of causing hypoglycemia, and so that's generally why metformin is preferred. It doesn't have a hypoglycemic effect, so you can see very little change in terms of their blood sugar going too low rather than being too high. In terms of second line therapies, I'll go through more of these in a minute because a lot of the letters are quite hard to determine what medications we're talking about. However, there has been quite an area of growth in terms of what medications are available. and so I will go through these a bit more. Very much in terms of the choice of the treatment, it really depends on their other risk factors. So if they have heart disease, if they have angina, if they have various other diseases, pancreatitis, it really does affect which we go to next. So it's not really a stepwise therapy as nicely as we would hope. So here are the drugs available for type 2. I haven't included the insulin for the purpose of this slide. However, as you can see, I've listed some names of the medications and their classes here. In terms of metformin, as I mentioned, it's euglycemic, so it won't cause hypoglycemia, which is a big part of why it is first line for these patients. As I mentioned before, it is renally excreted, so we do have to be conscious of the patient's renal function. And it can cause some stomach upset in the initial phases, so giving it with food can help to minimise those effects. Sulfonylureas used to be quite popular, but again, as I mentioned, they can cause hypoglycemia as well as weight gain, which makes them less preferable in a population who are likely to have a higher BMI. Again, depending on which drug, it does have varying degrees of hepatic and renal impacts, so that's something to consider as well. Some of the newer agents are the SGLT2 inhibitors, and so these are working in the kidney to try and increase the excretion of glucose through the kidneys. But for this reason, they obviously require good kidney function to work. And this can run into a problem if you're not checking their kidney function on a regular basis, because then it will eventually lose its effect. In terms of side effects with this one, you are basically peeing out sugar. So in terms of infections, they love the sugar. So urinary tract infections, vaginal infections such as thrush can be a problem in this group. Despite this, though, there has been some recent evidence that has really come out to support their use in terms of being protective against cardiovascular disease, death and mortality. DPP-4 inhibitors are oral medications that enhance the effect of incretins, which, if you remember from preclinical years, enhance the release of insulin. And again, GLP-1 agonists such as exenatide and liraglutide work quite similarly, but these are actually injected. So for obvious reasons, that makes them less favourable in terms of the patients. But because they work by a similar method, their side effects are quite similar as well. So pancreatitis and GI upset can occur with both of them. And if patients had a history of pancreatitis, it's normally a reason we would avoid their use. And the last two are far less commonly used. So the first one is acarbose, which basically inhibits the absorption of disaccharides and polysaccharides from the gastrointestinal tract. And basically they just travel through the intestine instead. So for this reason, it can cause gastrointestinal upset and diarrhea and that sort of thing. And again, makes it less favourable. As I mentioned before, pioglitazone and rosiglitazone have fallen out of favour. They are thiazolidine diones, which I wish you luck trying to pronounce that as a class, but they are having DNA effects in terms of promoting insulin signaling. In some ways, it suggests the role in type 2 because we have got that decreased sensitivity, and therefore their role, it seems logical in that regard. But because of their associations with heart failure in some of the research, this has meant that they've fallen quite a bit out of favour. And so I won't go through this slide, but it is helpful to look over again in terms of where these drugs are really acting, and also how we can affect different things with different combinations of drugs. For example, you wouldn't use generally a DPP-4 inhibitor with a GLP-1 agonist because realistically you're working on the same pathway, so there isn't that logic there in terms of managing diabetes. So this is a helpful picture to look at. Finally, in terms of complications, macrovascular, microvascular is the best way to look at it. So thinking about the big vessels to the heart, to the brain and peripherally, we can look at the side effects in terms of each of those and the potential risks from that. So obviously coronary artery disease, peripheral vascular disease and stroke. are big risks with poorly controlled diabetes. And so obviously for that reason, we try and control the cardiovascular risk factors across all different areas. So not just in terms of their diabetes, but their blood pressure, their cholesterol, and smoking cessation, obviously for any patient. In terms of microvascular, I've got some pictures here. Obviously diabetic retinopathy in terms of their eyes can be non-proliferative, and proliferative can be helpful to understand the difference between the two. And it also can lead to cataracts as well. And they can also have kidney damage, which is obviously why we continue to monitor their kidneys and encourage compliance. In some patients, they get to a point where they require dialysis because they've had diabetic nephropathy developing to a point where they need that. And finally, obviously, in a diabetic exam, we for that sensation loss, but it's important to remember that beyond that peripheral signs, we can also have autonomic symptoms of that neuropathy. So things like erectile dysfunction is obviously a hard one to ask about, but maybe a sign that the diabetes is not as well controlled. And again, we take the same approach in terms of managing those complications. So this is more just for an added point, but whilst there's DKA in type 1 diabetes, there is a similar condition in type 2, which is HHS. It had previously been called HONC as well. But basically, because there's still insulin available, we don't get to a point where we see DKA. However, we do start to see some changes in fluid shifts because of the abundance of glucose present. And so this can be a response that occurs and can present similarly to DKA. So this is just for extra information, and you may get asked about it in years to come. All right, that's diabetes. So let's look at this question. You can just message me your answers. Okay, great. Everyone's got this one. So this one is Graves. It is quite an easy question in that it really does give you all of the signs of Graves in terms of the ocular changes and the signs of hyperthyroidism. Just make sure you read all the responses because you may have picked hyperthyroidism if you hadn't read all the options. Okay, and this one. Okay, good. Okay, so yeah, I've had a few people respond back, and this one is hypothyroidism. In terms of the signs, again, it really is just about knowing the signs of hyper and hypothyroidism. In terms of the other diseases, I will be going through some more of those in future. So if you weren't totally familiar with that, we'll be able to exclude some of those others further down the track. All right. This is the last one for this section, and then I'll go through some more conditions. All right, great. So the most common side effect that Monash will ask you about is agranulocytosis. So this can actually be a feature of carbimazole and propylthiouracil. So it is something that you would need to check their blood counts, including the NFBE, if they were to be commenced on treatment. Okay. Okay, so this is just a summary table. It's really just trying to make sure that you've got the initial features of thyroid disorders down pat, because it will make the progression through the disorders much easier. So in terms of whether it's primary or secondary, they can quite often ask, where is the level of the injury in terms of thyroid disorders and other disorders as well. So this is something to come back to. For obviously just remembering that T3 is the faster acting form with a shorter half-life. It's definitely more potent and less strongly bound to plasma proteins. So in terms of its use, it's quite limited in terms of only being used when it's really needed. So in this case, that would be myxedema coma. As opposed to T4, it's slower acting, so it can take 6 weeks to have full effect. And therefore we need to time when we take levels, but it is the more commonly used one in symptomatic hyperthyroidism. So I've just included a couple of different ways that you can remember the symptoms of hyperthyroidism in terms of everything being sped up is one way of thinking about it. Some people like acronyms, so I've included that as well. And obviously the picture gives you a good idea of what you would look for in your head, but just thinking through your thyroid examination as well as to which features you'd see in hyper versus hypo. So in hyperthyroidism, you can break down your symptoms into systems as well. And the effects, it is quite simply stated in the question as to whether it's hypo or hypo. So just becoming familiar with these. In particular with hyperthyroidism, thinking about the signs of Graves' disease, which particularly will relate to their eyes, the presence of pretibial myxedema, and just remembering that even though it says myxedema, we actually are talking about hyperthyroidism, not hypo. You can also see nail changes and a goiter, but these are not always present. And then thinking about the signs that you can see as well on physical examination. So in terms of causes of hyperthyroidism, the most common is definitely Graves, but you can also see adenomas, thyroiditis, cancers, and iatrogenic causes. Always remember to ask medications because they may already be being treated but are being overtreated, and that can precipitate hyperthyroidism. The secondary causes are far less common in this situation. In terms of thyroid investigations, don't forget an ECG. Commonly in hyperthyroidism, we do see more common occurrence of arrhythmias like AF. So that's always an extra point that you can tick off rather than just the thyroid function tests. In terms of Graves' disease, we particularly see changes in the receptor antibodies, such as anti-TSH and antithyroglobulin. Anti-TPO are more involved in hypo, but you can order them for reassurance. In terms of imaging for a mass in the thyroid, this is something that can come up. So thinking about your methods of testing in terms of an ultrasound, the radioactive uptake, a fine needle aspirate, or just a biopsy itself, because this doesn't always detect the problem. So when you're thinking about management, don't forget to think about lifestyle as well as symptomatic and pharmacological treatment, particularly in this case, because as I said, the effects on the thyroid generally are not fast acting. So as well as bringing thyroid levels back up, bringing them down is also a slow process. So trying to adjust factors that will decrease their symptoms in the meantime will definitely help. So in terms of hyperthyroidism, caffeine obviously fills you full of energy, so that would contribute to symptoms as well as smoking. And you can use propranolol as a non-selective beta blocker in the meantime while you're waiting for the treatment to work. Pharmacological management is quite common, so carbimazole and propylthiouracil, or PTU, are the two agents that we have as options. As I mentioned before, agranulocytosis is a problem for both, and liver damage is a problem for PTU. For this reason, carbimazole is preferred, except in the cases of thyroid storm and in the first trimester of pregnancy. So in thyroid storm, PTU can prevent the conversion of T4 to T3. And for that reason, that's obviously favourable in thyroid storm or thyrotoxicosis. And in that first trimester, carbimazole is considered a teratogen, so that's why we prefer it in that case. Other options include iodine ablation, but that doesn't always treat all the symptoms yet. Also, surgically removing the thyroid will quite obviously reduce the amount of circulating T3 and T4. And in terms of this eye symptoms of Graves, treating the hyperthyroidism doesn't always reverse the symptoms, particularly in terms of the eyes. So smoking cessation and lubricants can help it as well. Moving on to hypothyroidism, it's essentially the opposite in terms of symptoms. And again, I've put some ways that you can remember the symptoms. But again, thinking through it in terms of an examination always helps as well. So quite simply, their symptoms are quite the opposite to the symptoms of hyperthyroidism. And thinking about the signs of severe disease as the case of myxedema coma, such as the mental state impacts and effects on temperature regulation, effects on electrolytes and glucose levels. So as you can see, the effects of the thyroid are wide reaching. You can consider all those figures when assessing the patient. In terms of causes, again, there's multiple causes, but commonly Hashimoto's thyroiditis is the autoimmune cause. And despite it being quite obvious, removing the thyroid is a common cause of hypothyroidism. And sometimes we forget about that. The most obvious cause can be right in front of us. So checking if they've had treatment before for overactive thyroid is always a useful question. Congenital is the most common cause in young children, but this is something you'll come into next year. In terms of investigations, again, with the antibodies, we can look at anti-TPO, which is the presentation of particularly Hashimoto's and thyroiditis can change over time. So sometimes they present initially as hyper and then become hypothyroid. In terms of hypothyroidism, replacing with levothyroxine, which is synthetic T4, is important. And in terms of risk factors, you just need to be conscious of in the elderly, they are particularly sensitive to the effects of it, particularly if they've got existing heart disease. So we do tend to start lower and titrate slower in that population. And so just as a final slide, I've included this as a comparator in terms of the symptoms and signs, and I just included this for revision purposes. And the last part of thyroid is looking at the nodules and cancer. And I will just say that this was not my forte last year. So I've just included some information and definitely want to say thank you to the slides from previous years, particularly Tushar's last year. He had a great summary slide. So if you want to look at this in more detail, I definitely recommend them. But pathology-wise, this seems to be the most essential points, and it does come up in the clinical exam as well as pathology. So I just tried to include some information about each of the types of cancer, obviously remembering the most likely cause, but also some pathology information as well. Oops, I forgot to get rid of the answer. Okay, so I just wanted to point out with this one is that despite the fact that the patient has symptoms that suggest that he may have Cushing's, it can present similarly to hemochromatosis. And the thing that differentiates it in this question is the tanned skin. And so similarly to this will come up in future slides, but there are some endocrine disorders that do present with tan skin, which confuses this picture a little bit. So don't just automatically if you see that the blood glucose is up and they've been on steroids and that sort of thing. All right. You should be able to do, oops, this question. Okay, good. So as opposed to the previous question, it is quite similar in terms of the symptoms that we've got going on, but noticing the impact on menstrual cycles as well is particularly useful information in females. And so again, slide here of Cushing syndrome. So I'll just go through that now. Let me. So in terms of causes for Cushing's, it's important that you remember that it includes Cushing's disease as well as Cushing syndrome. So Cushing's disease being the primary cause in most cases where you've got an adrenal tumour, or whether it's an ectopic source. So obviously we can give steroids, and this is a cause that could have been confused in the hemochromatosis question. However, we do also have causes that can be ACTH independent or dependent. And the reason I'll bring this up is that obviously we need to consider at what level is the problem. And this actually guides our investigations quite a bit with these symptoms as to identifying the level of the cause. And so I've just included a table down here of the potential causes and the impacts that they will have on the cortisol and the ACTH levels. Again, looking at the symptoms, here's a nice acronym if you like them, but particularly thinking head to toe, I think is the most useful way to remember it. The thing I do want to focus on though in this case is the investigations for Cushing's. So in terms of a bedside investigation, if you're suspecting Cushing's, we can do the salivary cortisol, which is done at night. We can also do a 24-hour urine collection, but this is obviously less favoured by patients. Or we can do a low-dose dexamethasone test. So I will go through each of these tests in a bit more detail. And then from that point, we can progress to urine levels. And then, as we've got in the previous slide, whether that's normal or suppressed would guide what's likely causes are. And then we can do further imaging or further testing to further identify the causes. Okay. And so I will explain the low-dose dexamethasone test is using 1 milligram of dexamethasone. And basically what this would normally do is if you have a normal setup in terms of your response to endogenous steroids being given, your ACTH level would be normal because it's not at the, it's being suppressed at the level of further down. Sorry, I'm not very good at explaining this, but I'll show you further on the next slide as well. But at normal, result would show suppression at both the low and the high dose. In the case of Cushing's disease, which at the level of pituitary adenoma, this would suggest that the problem is coming from higher up, which would explain why we have a higher level of ACTH. And again, an ectopic ACTH tumour, such as a lung tumour, would cause elevated levels of ACTH, which then trigger higher levels of cortisol. And when there's a higher cause of that increased cortisol, giving dexamethasone won't change that at a lower dose. But in the case of a higher dose, Cushing's is suppressed because it can't completely overwhelm the effects of that dexamethasone. Now, if it's primary Cushing syndrome, which is at levels, giving dexamethasone will make no difference to the levels of cortisol because it's just secreting its own. But this will have negative feedback on ACTH leading to its low and undetectable level. If you have any questions on that, if I've explained that really poorly, feel free to ask me a question about it. Yeah, sometimes it's just working through these tables and setting up your own way of thinking through that. So in terms of management, it really does depend on the underlying cause. So if we're giving steroids and that's the cause of the high levels, then obviously we would stop or decrease the dose. If it's Cushing's disease, we would remove the pituitary adenoma. If it's an adrenal adenoma, we can remove the adrenal gland. Or if there's an ectopic source of ACTH, such as a lung cancer, we'd obviously remove that. Sometimes in the meantime, this isn't something that happens straight away. So we can use ketoconazole to reduce its synthesis while we're awaiting surgery. If you have any questions about shingles, I'm just going to move on to Addison's. So Addison's is considering adrenal insufficiency, and this affects the levels of all adrenocortical hormones. And this is again an autoimmune process. So the patterns of developing autoimmune disease can include Addison's. And so it's important to remember what the adrenal gland does produce. So mineralocorticoids such as aldosterone will be decreased, glucocorticoids will be decreased, as will androgen levels as well. The impacts are mostly seen in terms of the mineralocorticoids and the glucocorticoids, because of their important function in terms of electrolyte management and energy regulation. And so these are the most common symptoms that we do see. Because Addison's is at the level of the adrenal gland, we do find that the pituitary continues to secrete ACTH to try and increase the release of these hormones. And that's why we can actually see hyperpigmentation, which they can get the tan bronzing of the skin, which is seen in Addison's. So as I've mentioned, there is electrolyte disturbances because we are losing aldosterone. Well, we actually don't have aldosterone present. And aldosterone would normally cause the release of potassium into the urine and uptake of sodium. So because of this, we see hyperkalemia and hyponatremia when it's not present. And this can manifest in a number of different symptoms, which can be seen here. So the weakness, fatigue, dizziness, weight loss, salt cravings, muscle aches and pains, nausea, vomiting, abdo pain, and diarrhea. In terms of cortisol, we can see impacts on your ability to fight infection, as well as your blood sugar control and your mood can be quite varied in terms of its effects. And in terms of androgens, we don't tend to see these quite as present as the other signs, but you can notice decreased body hair and decreased libido, particularly in females. In terms of investigations for this, we can look at the FBE and electrolytes. We can also look at the blood sugar level and the serum cortisol, as well as the serum ACTH. Obviously, these signs will correlate with the level of dysfunction. And in this case, you can see the results here. We can also do ratios with renin and aldosterone, because normally this process would be under the guise of renin's, the renin-angiotensin aldosterone system. So because there's low levels of aldosterone, you get hyper secretion of renin, despite that low level of aldosterone. We can also do the ACTH stimulation test, which gives us an idea of the level of the dysfunction. So often Addison's disease presents in crisis. We need to act acutely as well. In the acute sense, we need to think about electrolytes. We also need to think about the blood glucose levels. And this is for that reason we're looking at levels of normal saline and glucose and insulin to adjust the glucose levels. From a long-term perspective, we need to replace the glucocorticoids. So that's the hydrocortisone. In the immediate sense, it's the dexamethasone because it is faster to act and it can be given intravenously. In terms of long-term management of the mineralocorticoids, we can use fludrocortisone. And in some cases, we can consider androgen replacement, but this isn't always the case. All right. The next couple, there's some more here. I'll go through them as much as I can, but in terms of them coming up on exams, it really is just identifying the symptoms, identifying the electrolyte changes, and having a bit of an idea of how it will present and how we might investigate it. From memory, there was less about treatment because it's more about being able to recognise these diseases. As opposed to Addison's, where we had low levels of aldosterone, hyperaldosteronism obviously is the opposite. And for this level of we renin, unless the cause of the hyperaldosteronism is due to excess renin, but that's far less common. You'll hear Conn syndrome will come up, and that's a commonly associated cause of hyperaldosteronism. And sometimes the two terms are used interchangeably, but it's not always the only cause. So in the case of Conn syndrome, it's an adenoma that secretes aldosterone. And for this reason, we see increased loss of potassium, increased gain of also involved in that in the kidneys is potassium hydrogen ATPase, and we also see increased pH in the blood due to the hydrogen ions being moved into the urine. The symptoms are quite simply the opposite of having low levels of aldosterone. So we see higher blood pressure, facial flushing, and we see arrhythmias from having low potassium, and obviously fluid retention because of those fluid shifts. Again, we look at things like ECG because of the electrolyte disturbances. We can look at the urine itself and do an analysis of what's present in the urine. We can also look at the electrolytes and ratios of aldosterone and renin. And we can trial a fludrocortisone suppression test, which if it's at the level of the adrenal gland being the problem, this generally won't suppress its impact on aldosterone levels. However, if it's coming from up high, this can do so. We can also do imaging of the abdomen to look for things like the adenoma, such as Conn syndrome. And to treat it, we use antagonists of aldosterone, which are spironolactone and eplerenone, and obviously remove the cause, which in this case is most likely the adenoma. So Pheo, I'm just including it is a red condition on your matrix. So I've included more detail if you want to read it. But the most essential thing is that it is a rare tumour and it causes the release of adrenaline and noradrenaline. And it commonly arises from the adrenal medulla. It has some associations which have come up in path before in terms of the von Hippel-Lindau syndrome and multiple endocrine neoplasia syndromes as well. The symptoms are really just overactivity of the sympathetic nervous system, and you can check the urine for the metabolites of those, but you're less likely to be asked about that. It's more just what is Pheo and what are the associations. All right. Just wondered if people can have a go at this one for me. Okay, getting some mixed answers here. So this one is a bit of a trick question. So as you would expect, we are seeing some signs that there is an endocrine abnormality going on, but I think the most important line in this is that there was no evidence of a cellular mass on MRI. which essentially actually rules out quite a lot of these. Posterior communicating doesn't really present with, is more like a stroke symptoms, so that doesn't match. Prolactinoma would show signs of a cellar mass because the cellulosis occurs where the pituitary gland sits, so that would also rule out a pituitary adenoma. Pineal gland is not really involved in what we're looking at, so the answer is actually C. Some people sent through F, but obviously just make sure you finish reading the question to see that. So hypopituitarism is when you've got lower functioning of the pituitary gland, and this can affect either the anterior or posterior or both. Most commonly it's the anterior, and this can be caused due to a mass effect. Sheehan syndrome will come up next year. That is often following a postpartum hemorrhage. In females, they lose so much blood that their pituitary becomes underperfused and therefore non-functioning. But again, don't worry about that till next year. You can see different symptoms based on which hormone is deficient. And so that's when it's important to know the function of each of the hormones. To treat it, we basically replace the hormones that are relevant. So depending on the age of the patient, this will dictate what we need to replace. And also which hormones are effective will dictate what we need to replace as well. In terms of investigations, it does tend to correlate with in terms of testing levels of that, but the other ones tend to correlate quite well. Pituitary tumours, again, is quite similar to the effects of if you've got low levels in hypopituitarism. If you have higher levels, this tends to be how a pituitary tumour does present. And so you can see from this table the impacts of having hypersecretion of each of those hormones. As you would have learned in preclinical, the bitemporal hemianopia is still relevant. And in some cases, you will see these signs, but if the tumour is not big enough, you may not always see this, so it's always something to consider. In terms of treatment, it will depend on the hormone that's hyperactive, and if it's multiple, you may need multiple treatments, but obviously surgical resection is the best option, and then obviously subsequent replacement of the hormones that are affected. Another rare condition is diabetes insipidus. So this is when we have ineffective action of the antidiuretic hormone, which means that we don't concentrate urine. And so we lose lots of dilute urine, so we lose lots of fluid, and so we get symptoms like polyuria, nocturia, and increased thirst to try and replace that. This can come from a central level where we're not producing enough antidiuretic hormone at the level of the pituitary, or we can have it acting at the side of the kidneys where the kidneys doesn't respond to it. And so there's a number of different causes for each. There are some cases where it's psychogenic, which is far less common, but you can do a water deprivation test to exclude this. And in the case of a water deprivation test, if it's just a psychogenic cause, the patient will stop going to the toilet as frequently. But if it's a true diabetes insipidus, they will still keep going to the bathroom no matter how much you deprive them of water. In the case of desmopressin test, this is again another test that we can compare central versus nephrogenic causes, where if it's a central cause, giving desmopressin will fix it, essentially, because this is essentially replacing that ADH. But if it's a problem at the level of the kidneys, it won't correct it. And so for that reason, the management depends on the level of the problem. So if it's a central cause, we can continue to use desmopressin to stimulate the response of ADH at the kidneys. If it's a nephrogenic cause, it doesn't respond quite as well. And so we try and address the underlying cause wherever we can. We also restrict sodium in order to try and restrict the amount of sodium that goes out into the urine and therefore the amount of water that goes out with it. And we do encourage patients to drink a lot more as well. Okay, just another question. Okay, good. So this can come up in a question. So the answer in this case is hypocalcemia, and I'm going to go through those a bit more now. So we can see multiple different effects on calcium depending on different hormones. And so I've popped this slide in for completeness, but I won't go through that for today. But looking at hyperparathyroidism, it's important to remember that parathyroid hormone increases the absorption of calcium into the blood. And when the parathyroid's overactive, we can find that we have too much calcium in the blood, and therefore we can get symptoms of hypercalcemia, which is this bone, stones, groans, psychiatric overtones, and then on the throne was added in at some point along the way. And so obviously if we have an overactive parathyroid, we can see this becoming a problem, and we need to treat that hypercalcemia if it does occur. And so the management is briefly outlined there, but less important for a red condition. More importantly, thinking about the causes of hyperparathyroidism can be an adenoma of the parathyroid. When we have chronic hypocalcemia, such as in vitamin D deficiency or chronic renal failure, where we fail to activate vitamin D, that can be present for a long time. That can progress to tertiary hyperparathyroidism, when the parathyroid just becomes unresponsive to any stimulus to slow down. So that is the three types. Hypo is the opposite, and the most common cause is due to damage during the removal of the thyroid gland. And this is by far the most common cause. There are also other causes, but essentially in this case we don't resorb calcium back into the blood, and so we can present with hypocalcemia. So paresthesias, muscle cramps, tetany, Chopsticks and trousseaus, as the Chopsticks with the tapping on the cheek, and trousseaus with the blood pressure cuff around the arm and then getting tetany after leaving that on for a couple of minutes, are some signs that you can see in hypocalcemia, and this corresponds to our case before. In this case, you'd obviously replace the calcium, and that's why it's defaulted to be replaced after a thyroidectomy in case that the parathyroid has been damaged. All right, I'm just going to skip this question because just for time purposes. But the last condition that is a green condition for you guys is osteoporosis. So there are a lot of risk factors for osteoporosis, but the big thing is knowing the definitions of what defines osteoporosis. And for that reason, I'll just show you this slide. So -1 to -2.5 as a T-score signifies osteopenia, and -2.5 or less signifies osteoporosis. You can be asked the difference between a T-score and a Z-score, which unfortunately is a bit of epidemiology that can come up in exams. And basically what you need to understand is that the T-score is comparing the bone density to a young adult, generally a 30-year-old male. But this is actually the most commonly used score that we use. The Z-score is when the bone mineral density is compared to someone of the same age, sex and ethnicity, but it's actually very rarely used. So it's only in premenopausal women, younger men and in children. There can be multiple causes for osteoporosis, but obviously in postmenopausal women, the loss of the protection of estrogen becomes particularly important. But we can obviously screen for osteoporosis with a DEXA scan. In terms of management, it looks at addressing the risk factors, so looking at things like caffeine intake, alcohol and smoking, replacing calcium and vitamin D if they're deficient, encouraging regular exercise, physio, falls prevention, and stopping agents such as steroids, which can contribute. In terms of management, we have multiple options in terms of medications. So bisphosphonates are by far the most commonly used. There's multiple options in that class, including oral and intravenous options. In more recent times, Prolia has become quite popular. It's denosumab. It's a monoclonal antibody against rank ligand, which is important for osteoclast formation, and therefore we can decrease fractures with either one of these drugs. The good thing about Prolia is that it's a once every 6 months injection, but with both bisphosphonates and denosumab, we do have to be careful about osteonecrosis of the jaw. There are increased rates of atypical femur fractures and esophagitis with bisphosphonates, which can lead to the use of Prolia. SERMs are selective estrogen receptor modulators, which include raloxifene and tamoxifen. These have selective estrogen effects on bones and other tissues, whilst having negative impacts on tissues like breast and endometrial tissue, which differs between the different medications. But this can obviously be protective in postmenopausal women. Teriparatide is the last option that I've listed there. Despite it being recombinant PTH, it opposes the effects of PTH and therefore maintains calcium in the bones, but it does increase the risk of osteosarcoma, so we don't use that in the long term. And I think this is the last topic on your matrix. I'm very sorry to have rushed through the last one, but osteomalacia is equivalent to rickets in children. And so it's basically just soft bones when the bones are not as mineralized as they could be. And osteomalacia is the term we use in adults. The most common cause is low vitamin D, whether absorption or when it's not being activated, such as in liver or kidney failure. And so this increases the risk of fractures and decreased strength in the muscles because of this. And so we supplement as we need to. I've just left some questions at the end there, but I will pop the answers in the post slides. If you think of anything later, please feel free to send me an email or send me a message on Facebook. I just want to wish you guys all the best with your exams. It's been a really tough year for you guys, but I think you're all doing really well. And looking forward to seeing you in hospitals next year. Thanks, guys.
Thank you so much, Kaitlyn. It was a really wonderful presentation, and I know going last is a bit, especially on long days, a bit hard. But thank you so much for putting the time out to prepare this presentation, and to everyone else as well. With that, we come to the end of our 2-day revision lecture series. If the slides and recordings will be up by tomorrow. If anyone has any questions, you can feel free to contact me. I'm happy to pass along any questions you have to the lecturers themselves. Otherwise, again, it was great to have you all. Best luck for the exams. Best luck for the PATH exam tomorrow. It's at 12. Don't forget that. I'll put up a post soon. Can we write on paper for tomorrow's PATH paper? No, I don't think so.